Welcome to the Breaking Barriers podcast. This is our second episode with Dr. Iverson, ENT at University of Kentucky Children's. I am Gina Polisek and will be your host for this episode. For those that listened to our first episode with him about hearing loss, we are excited to have him back for round two to discuss cochlear implants. This episode is exciting because our usual host, Crystal, is a guest and will be answering questions as well. Dr. Iverson did the first cochlear implants on a Trisomy 18 kiddo on her son Gunnar. I will turn it over to Dr. Iverson to do a brief introduction for those that may not have heard our previous episode with him.
Thank you so much, Jenna. And yeah, so I'm at the University of Kentucky, and I've been here for 10 years now. And my role is I'm the chief of pediatric ear, nose, and throat, or pediatric otolaryngology here at the University of Kentucky. I'm also the vice chair for clinical affairs within the department. And my area of interest is pediatric ear, nose, and throat, especially specializing in hearing loss. Do multiple aspects associated with pediatric ear, nose, and throat, but one of my particular interests is hearing loss, as well as implantable devices for children with hearing loss. I did my residency at the Medical College of Georgia, and then did a fellowship specifically in pediatric otolaryngology, focusing on implantable devices at the University of Alabama, Birmingham program.
Wonderful. We're glad to have you here. Could you give a brief explanation of sensory or neural hearing loss and the specific types of hearing loss that would be candidates for a cochlear implant?
Sure. So sensorineural hearing loss, and we had discussed a little bit in the prior podcast, but I'll just kind of briefly review. So we have two types of hearing loss. Basically, we have a conductive type of hearing loss, which is anything that impedes sound getting from our environment out in the air down to the cochlea, which is the the inner ear, the nerve part of the ear, which is the snail. It looks like a snail shell, and it has these nerve elements inside of it that that gives sound, that sense that mechanical energy from sound waves, and then translates it into an electrical signal that then is transferred up to our brain stem and to our temporal lobe, which helps us to process that information. So conductive hearing loss is anything up to the cochlea. Sensory neural hearing loss is anything from the cochlea up to the brain stem and through to the temporal lobe. So it can be anything related to either the cochlea itself. So for example, that cochlea, that snail shell, sometimes we can see where that snail shell just doesn't form the way it typically does. Typically it has 2.5 turns to that snail shell. So sometimes a cochlea can form where it's smaller, either where it has fewer turns or it's just a globular structure. And certainly those elements inside of the cochlea, because they didn't form the way they typically do, you can have some hearing loss from that. So it could be kind of the formation of the cochlea, but it could also be some of the elements within the cochlea. So that cochlea, if you were to roll it all out, it looks almost like there's this membrane. It's called the basilar membrane, where at one end it senses high notes, and the other end it senses low notes, just because of the vibrating frequency of that basilar membrane. And so we have hair cells that are along that membrane. And so if that basilar membrane, kind of at the thicker part of it, where it detects high sounds, if those nerve elements that are right there, they're little cells that have these small hairs on them. So when that basilar membrane vibrates, depending on which sound it is kind of associated with, the little hair cells will kind of bend and cause an electrical signal that stimulates up to the nerve. And so there can be issues with either those hair cells themselves, where they're either damaged, or there can be issues with kind of the proteins involved in kind of building those hair cells. What happens with those hair cells is when they bend and they do what's called depolarizing, they open up gates for different electrolytes to come into the cell. And it's that change of, and they're positive charged electrolytes. And when they come into the cell, that's what causes that initiation of an electrical signal. So sometimes there can be problems with those gates or the proteins or the genes that make those proteins that that are kind of involved in that signaling, transferring that mechanical energy to the electrical energy. So, and sometimes you can have a perfectly healthy cochlea otherwise, but just those hair cells are damaged. So then if we kind of go further upstream from the cochlea, and I guess I could say, so genetics can cause issues with those hair cells. There can be drugs or ototoxic drugs that can damage the hair cells. You can have viruses or bacteria, infections that can damage them. Certainly trauma can affect them. So lots of different things that can lead to that sensory neural hearing loss. So kind of up from the cochlea, sometimes you can have a smaller nerve than typical, either a cochlear nerve hypoplasia or an absence of a nerve even. So that can cause it. And then there can also be anything that can affect the pathway of signaling from the cochlea up to the temporal lobe. There's something called auditory neuropathy, which is where the cochlea can actually be normal, but kind of the progression of that nerve pathway up to the brain can have some basically it doesn't fire appropriately, and so you can have actually a normal cochlea, but you can actually have a perceived sensory neural hearing loss. So those are basically in a nutshell what the different types of sensory neural hearing loss that you can have. And it's it can either be, it's not all or nothing is what I tell folks as well. So I tell folks it's not like a light switch, right? Where it's
Right.
either you have it or you don't.
Right.
There are different aspects of sensory neural hearing loss where some people can have perfectly normal hearing in like the low to mid frequencies, but maybe they have hearing loss in the high frequencies where just those high frequency nerve cells are damaged. That kind of is what happens to most of us throughout the wear and tear of time, as we're exposed to noise and things like that. That's usually what goes first are those higher frequency. Sometimes they can be flat, where you have low frequency, mid frequency, and high frequency, where it can be either mild, moderate, severe, or profound. So sometimes you can still have some function, but it's not complete. So you either have a mild loss, basically have to turn up the volume a little bit, versus, a severe loss where you have to turn up the volume quite a bit in order to hear. So there's a, there's not just an all or nothing, there's like a shape to the hearing loss, just depending on which frequencies are affected. And then there's also a severity as far as whether it's mild, moderate, severe, etc. So that's hearing loss in a nutshell for sensory neural.
Okay, that's helpful. And are cochlear implants kind of like the main line of treatment for this specific type of hearing loss? And actually, before we kind of get too far into it, can you actually explain what a cochlear implant is for our listeners?
Sure. So if it's okay to first answer the question on cochlear implants being the main treatment for it. So in general, for sensory hearing loss, cochlear implants are not the first line treatment for sensory neural hearing loss, because most hearing loss, if you're going to have it, is not quite to the severe to profound range. So the mainline first treatment that we utilize for folks with hearing loss are hearing aids. And so that's basically where we're taking sound from the air, amplifying it up, basically turning up the volume specifically towards whatever that individual's needs are. So we mentioned before, someone may have only high frequency hearing loss. So using the hearing aids and the programming through a trained audiologist can kind of turn up the volume just on what is needed for a particular individual, and basically tune that hearing aid specifically to an individual's needs and hearing loss. So now that is effective up until about severe to profound hearing loss in children. So once we get to that severe to profound level, typically we're not seeing much benefit from that amplification or from the hearing aid. And the way I describe it, when I was going on road trips, you had to listen. You didn't have Sirius XM radio, right? You had whatever was broadcasted from whatever station you were driving by, right? And so
Yeah.
you were close to this, wherever, the tower was being broadcasted. You had a great signal, sounded great, right? So, but as you continue to drive further away from that radio station or that broadcasting signal, it becomes less clear, right? So it becomes more staticky. So you're like, well, maybe if I turn it up, that'll help, right? So you turn it up a little bit, you're like, okay, yeah, I can kind of still hear what's going on. But it gets to a point where no matter how much you turn it up, all it's going to amplify is just noise. Right? So it's even though you're turning up that volume, whatever signal or sense that you're getting from it, it's hard for your brain to make sense of it. So sometimes that's the case with hearing loss. That's kind of how I think about it. So if you're in that profound to severe range, can you turn it up? Can you hear a beep? Maybe, but can you actually understand speech or language or communication? So that's where if hearing aids are not doing that job, then that's where cochlear implants can certainly come into play. And so what a cochlear implant is it's not a hearing aid. It's not amplifying sound. It's a device that is implanted into the ear, and it's actually we make a small incision back behind the ear, and we implant a device that has a receiver stimulator, but then it's connected to an electrode, which is a longer thin wire, and this thin wire has very small contact points that each are connected basically to a different wire that goes back to the receiver stimulator. And depending on the brand of the electrode, there can be either 12 to 22 of these contact points. And what we do is, so that those contact points go into the cochlea and kind of spiral around that snail shell of the cochlea, and basically bypasses the acoustical and the hair cell function of the cochlea and stimulates the nerve directly. So rather than having sound waves stimulate the nerve through the hair cells, it's an electrical signal that stimulates the nerve directly at that side of the cochlea. And as we talked about before, the cochlea has different, depending on where you are on the cochlea, it's associated with a different pitch. So basically, if you're stimulating a nerve kind of at the base of the cochlea, you're going to get a high pitch. If you're stimulating a nerve at the apex of the cochlea, then you're going to get a low pitch. So through stimulation of those different contact points on the nerve, then you can hear sounds with different pitches and be able to understand language and even music. So that is what a cochlear implant is. It's an electrical stimulating device of the cochlear nerve, bypassing the typical acoustical components.
I have a quick question. I know Gunnar, on his left ear, I think it was his left ear, all of the electrodes would not work, correct?
Right.
Or there was an issue. Can you explain a little bit more about that? Like, what is the reason behind that?
So, and it goes back to the one of the reasons I talked about as far as hearing loss that you can get. So is some cochlea have the complete full 2.5 turns. And so the cochlear implant electrode leads that are made these days, they're designed to kind of fit into that 2.5 turn of the cochlea. But if there are shorter turns of that cochlea, then you can't get that whole electrode lead into it. And that can either be just from the the way the cochlea formed without that full 2.5 turns, or it can be from scarring, or ossification, or where bone basically kind of grows into that fluid-filled part of the cochlea, because we can only put that, I mean, it's a very floppy little, noodle that you're putting into there. So you can't really put it through bone. So, so for that ear, there was less of that fluid-filled space. So we put it in, I think we got 10 electrodes of the 22 into the cochlea, and then the others were kind of hanging out of it. But then you can just turn those particular ones off and only use the ones that are actually within the cochlea. So that is an option.
That's very interesting. So since we have Gunnar's mom actually on here, to kind of share their story with the cochlear implants, what in like Gunnar's case, made him like the best candidate for cochlear implants?
So asking me or Crystal? Sorry, I don't want to step.
Probably you,
Okay.
unless Crystal can answer it as well as you can, but my guess is she'll probably lean on you for that one.
Okay. So what made him a good candidate? So, typically what makes individuals candidates. So, and there's a little bit of a history of this. So when cochlear implants first came out, they were FDA approved in 1984. So they've been around for a while, right? More than 40 years. And even prior to that, they were around, being implanted kind of on more of a trial basis. The first implant was actually done in 1961. So believe it or not, they go pretty far back. But as far as kind of modern day cochlear implants being used kind of in the mainstream, FDA approved since 1984. In children, though, in 1990, it was not approved for children under 2. But where's the problem with that, though? Because children who are not able to hear or have hearing impairment to a severe degree, basically, in order to develop speech and language, to understand spoken language and develop spoken speech, those inputs have to be in there basically as early as you can get them, because you can only understand speech and reproduce speech that of course you can hear. Otherwise, you can't make sense of it, and your brain just doesn't have the capacity to kind of go through the feedback process to verbally communicate or to understand or have that expression for spoken language. So we found through a lot of research, through a lot of decades, is that the earlier that you implant an individual who has hearing loss at birth, the better, because their brain is going to kind of better develop those pathways. So the longer you wait, the harder it is for that speech and language to develop. So it's now come down to about 9. Certain implants are indicated down to 9 months of age. So it's kind of stepped down throughout the years. So 9 months of age is the earliest FDA approval at this time. But there are people implanting earlier and having some good success. But particularly with Gunnar, so that's the age. So the other aspect of it is the severity of hearing loss. So in children, severe hearing loss, which is anything that's basically more than a 65 to 70 decibel hearing loss. So basically we're talking about, you kind of have to turn up the volume to as loud as, a loud piano playing, for example, in order to hear it. That's and that's not saying, oh, you hear it as loud as a piano playing, but it's like, if there's a loud piano playing and you can barely hear it as a whisper, that's basically what we're talking about with severe hearing loss. And then there's profound hearing loss, which is essentially like a jackhammer type of loudness, so 90 decibels or more. So children who are that not 65, 70 to 90 decibels under 2 years of age. Well, yeah. So for infants, it's that profound hearing loss. And then as you get up to 2 years of age, it's that severe hearing loss. But the lines do blur a little bit, just depending on how well they do. So you have to have a certain severity, but then you also have to have kind of how it relates to your speech and language development. So that's another thing that we track. So again, like we were saying before, just because you can amplify a sound, does that really mean that you're getting meaningful information from it? Or are you just getting a bunch of amplified noise? So we look for speech and language development along with that in children. But particularly for Gunnar, he had gotten into that severe range. So he was over the age of 2. We had tried the typical amplification, the standard hearing aids, and most implants companies and protocols need about 3 months of a trial at the minimum with hearing aids. Now I believe he was in them for longer, but he was older. I think he was 4.
Yeah.
But he had more of a progressive hearing loss over time to get
Right.
to that point where he was severe, where he was kind of more moderate. And then, certainly he had some fluid in his ears. So we were doing things like tubes and trying to manage, things that we could manage medically. But he did get to the point where he was in that severe range and not getting benefit from his hearing aids anymore. And so that was kind of what led us to, having that discussion as far as proceeding with the cochlear implant.
Okay. And our indications show that, or from what we know anyway, we've only heard of Gunnar having had a cochlear implant done for someone with trisomy 18. So what are your thoughts on doing this on someone with trisomy 18? And like in your kind of discussions with colleagues from, around the world, have there ever been any discussions around not necessarily trisomy 18 and interventions to this extent, but like even just like other genetic conditions that may be similar or, overlapping? Like, is it something that is common with, genetic conditions like trisomy 18, or is it something that is more rare that's done?
I do think it's certainly more rare, but I think it's trending towards being more commonplace. As people get more comfortable with the surgery and with as far as kind of prognosis of certain conditions, then I think more and more is happening. Certainly when Crystal talked to me about and I kind of talked about the options about cochlear implant, and I was like, well, I've never done it before on a child with trisomy 18. I think at that point in time, I hadn't really seen anyone of his age with trisomy 18, so I think just in general, we're seeing more children with complex medical conditions, living longer. And, because I think there's just a whole, a great thing that's happening where, there's kind of a paradigm shift of, well, this is not survivable. It's like, this is survivable and manageable and kids thrive, and so I think as that shifted, then, well, it's like, well, why wouldn't we,
Right.
why wouldn't we do all that we could do to help with his communication with his family and quality of life? And, we do have other folks that maybe have like CMV, for example, that have, could potentially have severe neurologic kind of associations with it as far as cognitive and developmental delays. And we're doing it with folks with CMV now more so than we used to, or children who have other delays, maybe just from being premature in the NICU. So I think as that's kind of improving, we're seeing more and more people that were like, well, why not? And I do remember calling my my mentor that I had in residency, and I was like, I don't know that anybody's ever done this before. I mean, do you think this is crazy to do this? I'm like, he's 4, he looks amazing, and his family is so motivated, and that's a lot of it too. Is you have to have good motivated families, and from what I've known, every single parent that I have met with a child who has trisomy 18, it's just like highly motivated. eager to do therapies and do all that they can, which I think is just amazing. I'm very blessed to be involved with folks in the community. And so it's just like, well, why wouldn't we do this, And so just because no one's ever done it before, that doesn't mean we shouldn't,
Right.
So if we've got the anatomy to do it, because that's another thing, is you have to have a cochlea with fluid inside where we can put in the implant. And specifically with Gunnar, he did have a little bit of that ossification where you kind of had to drill through. His anatomy was super small. I mean, I think I took longer than I typically do for a cochlear implant. His nerve for his face that you have to kind of weave by was kind of positioned in a different spot. So it's like, it was challenging, but I was like, well, if we can technically do it, we've got a motivated family, we've got someone who's, healthy, let's do it. So that was kind of what led to doing that. And I do think we probably will see more in the future as we see, through your efforts, especially, seeing kids with trisomy 18 and communities banding together and children doing better and living on into later childhood. And, it's just a beautiful thing.
Mm-hmm.
Yeah, you made me tear up a little bit talking there. I mean, it's amazing. It's what we truly need. So Crystal, I'm going to ask you a question then, kind of piggybacking on that. When you were first, having conversations like this with Dr. Iverson, finding that the hearing aids weren't really working to their best capacity for Gunnar, like what were you feeling when you found out that Dr. Iverson was, wanting to do a cochlear implant on Gunnar, and, as a parent, kind of what was going through your mind during that time?
Honestly, I was overwhelmed. I didn't know if he would even agree to do the cochlear implants. That was my thought. I was like, because it's never been done. I went through different websites trying to look and I could not find it anywhere. All I knew is that his hearing loss was getting worse. And so I was researching and I brought it up to him and he wanted to talk to other board members and stuff and discuss it with them, but he was open to talk about it, and very blessed to have met him, honestly.
Well, I
Yes,
feel
I mean, we've definitely kind of went through like advice to parents to kind of help advocate for this. I think we've kind of hit that on the head, just try to find people that are going to champion our kids. And,
Absolutely.
Definitely.
if it's a possibility for them and you find the right team, they'll be willing to do it. Now, obviously everybody's not a candidate for everything, but
Right.
there's help out there with the right people. So can cochlear implants like benefit other types of hearing loss, or is it mainly just and I always struggle to say this word, and Crystal and Kelly are gonna laugh at me, but the sensory neural.
Got it.
I really
Perfect.
struggle saying that word.
Beautiful.
Did I say it good?
Yeah.
Yes, perfectly. Mhm.
Perfect.
That time you did.
Now that I probably won't say it again for years after this, I got it down. So can it benefit like others, or is it primarily just the sensory and neural hearing loss?
It's really just indicated for the sensor neural hearing loss. Now, uh, there may be some mixed components, sometimes where there's a conductive and a sensor neural component, but you kind of bottom line, it has to be a sensory neural, because there are other ways to treat conductive hearing loss through other types of implantable devices or non-implantable devices even, but it really has to be a certain threshold and lack of benefit of hearing aids for sensory neural hearing loss with an appropriate cochlea and an anatomy.
Okay. And Crystal, so I know that it was noted that Gunnar didn't get the cochlear implants until he was a little bit older, and he had the hearing aids prior to that. Can you just share a little bit about like Gunnar's hearing loss journey, when you initially heard that he had some hearing loss, and then kind of when Dr. Iverson came into the picture for Gunnar?
Yeah, we found out that Gunnar had hearing loss when we were in the NICU and he'd failed multiple times. And then after that, we had scheduled an appointment, and I think our first ENT was not Dr. Iverson. Can't remember exactly who it was. And then kind of did my research and found out a little bit more about the different doctors, and somehow we ended up with Dr. Iverson, which I'm thankful for. Then we started out with hearing aids. We went through that probably going on probably 3 years, I guess, 2.5, 3 years. And his left ear just continuously got worse, which the right did too, but not near as bad as the left. And so I started bringing up the discussion about the cochlear implants, and we were talking about doing one ear at a time, doing the good ear, since we know we have better hearing in that ear than we do the left ear. So that's kind of just it was a long journey. Just it's kind of overwhelming when you find out your kid's hearing is getting worse. You don't really know what to do, so you just kind of research and do all the things you can and advocate for them. And thankfully, we had a doctor that would listen and open to different interventions with Gunnar. And Gunnar he has progressed quite a bit with the cochlear implants. It's very impressive just to watch him be able to hear the certain things that he could not hear before. And using his eye gaze way better. He can communicate way better. He does a lot of sign language as well, but he can be comical with the eye gaze. And I think once or twice he's tried to run Dr. Iverson out of the room and be like, how long are we got? But yeah, he's very thankful for him. And when we first had the first surgery, when he came out, it was very overwhelming just to know that he's going to be able to hear a lot better.
And is it common? So I know that we talked about how Gunnar's hearing loss actually progressed, and it sounds like that's kind of more rare. Is that true, Dr. Iverson, that, for it to kind of progress like that is less common, or is that something that you do see where kids, do progressively get worse as they get older?
We do see it, yes.
Okay.
So which is why, in general, folks with sensorineural hearing loss, I tell them, we're not just going to diagnose you with sensorineural hearing loss, give you a hearing aid, and see you later. We're going to continue to monitor you, especially with regard to whatever the etiology is or the cause. Certain things like CMV, we know will progress. Certain other genetic conditions we know will progress. So I generally like to have a very kind of routine following and repeat testing to monitor their progress. We're working with speech therapists so that speech therapists can continue to monitor their progression with speech and language and communication, not just verbal speech, but all forms of communication. So we want to make sure that all of that is kind of on track, so that if there's any point where we're not progressing as we should, then we can kind of re-engage and take a look at other options. So
Okay, yeah, that's helpful. And I think that's, good information for parents too, is that, to know that certain types of hearing losses can actually get worse. And so if their child has hearing loss and they're being told like, oh, we don't need to see you back for 3 years or something crazy like that, like you should consider that a red flag, because, some of this should be followed very closely. So I'm glad that we kind of noted that. Yeah, I mean, I don't really have any other questions. So I don't know if either of you have any other thoughts or anything like that related to cochlear implants or, just hearing loss in general, or Gunnars Journey. If not, we can probably wrap this up.
I did see a question as far as how long does the surgery tend to take,
Yes.
both entail, and I'd be happy to speak to that a little bit.
Yeah, let's do that one.
So in general, I give folks 3 hours per side, or per implant. And, a lot of that is because, I'm working in an academic environment where I'm training folks and everything like that. And plus there can be more challenging cases, certainly like Gunnar's, but I think his was about 3 to 4 hours, something like that. 3 hours maybe for the side. So we do make an incision behind the ear. It carries up into the scalp just a little bit. We do have to clip some hair. And then, we kind of take the ear forward, take a skin flap back. We have to drill out that bone back here. It's called the mastoid bone. And by drilling out that bone, basically we're preserving the covering of the bone for the brain on one side and then the brain on the other side. So it's a very, delicate surgery as far as we're having to preserve those kind of load-bearing walls, so to speak, and then get down to the cochlea, which the cochlea, we have to go through a very small window between the ear canal and the nerve that works the face, that facial nerve. So it's a lot of very kind of careful drilling with very small drills, going like nanometers at a time sometimes, just to make sure that you're not going to damage that nerve that works the face. We do monitor that nerve the whole time. But that's the nerve that comes out from the ear here and then branches out into 5 branches. And then, that's kind of what causes your eyes to close and you to be able to smile and those types of things. So a very important, nerve that we have to be careful about and preserve. So that's a lot of why it takes some time. And then if the anatomy is not how it is typically, we had to drill through some bone of the cochlea in order to get into that fluid-filled structure. Whereas typically there's a little, it's called the round window, that's just sitting right out there, and you just have to, open up the membrane to put the cochlear implant into it. But we affix that, there's a receiver stimulator that's affixed to the skull underneath the skin, and kind of anchor it down there. And then the wire goes into the cochlea, and we insert it into the cochlea, and then it just sits in there. And then we kind of seal off the cochlea with a little piece of muscle, and then everything gets closed back up. And basically, you've got that device that's under the skin. It's going down into the cochlea. Typically for young children, I'm watching them overnight, or if they have complex medical issues, I'll watch them overnight in the hospital just to monitor their oxygen and breathing, and make sure their pain's well controlled, and all that kind of stuff before going home. There's usually a pressure dressing around just to kind of help blood clots from forming, or bleeding from forming underneath the flaps. And that pressure dressing comes off after a couple of days. And believe it or not, kids do pretty well with the cochlear implant.
Mhm.
You would think, wow,
Yeah.
it's this 3-hour surgery per side. If you're doing bilateral, it can be up to 6 hours. So 3-hour surgery, you just spend all this time, you're doing all this drilling. But I would say kids do better from this than they do from having their tonsils out, which I do,
Yeah.
quite often as well. But so usually after a couple of weeks of just everything healing, settling down, usually about 3 to 4 weeks. Some centers will do it sooner, some will wait longer, but on average about 3 to 4 weeks. That's when you actually turn the device on. And I guess I should mention, after we've implanted the implant, and now even sometimes while we're implanting the implant, we have our audiology colleagues in the operating room testing the device, making sure it's working. We can actually test and make sure the nerve is even responding to the cochlear implant in the OR. So so that's a very nice feature for these implants that we're doing now, that we can test and make sure they're working. And then we can kind of know where to start from when we do that initial activation. And that initial activation, that's an interesting experience. I don't know if I was there for Gunnars, but it's having a sound or a sensation that you haven't heard or haven't experienced or haven't in a long time. That can be exciting. It can be scary. There's lots of emotions wrapped up in that first turning on of the device. And then there can be, several weeks to months of kind of fine tuning, where you kind of need to set, but it's an ongoing process of kind of fine tuning, mapping, working with audiology, working with speech. In many ways, I'll tell folks, yeah, the surgery is the easy part. The hard part is what the audiologists and speech therapists and parents and families, have to do to kind of use that implant and use the kind of the input from the implant towards that child's, best developmental potential. So.
And then are they like kind of like hearing aids? So like you take them off of your child at night. Is it similar to that where like it like pops kind of like clips on or like something like that, and you remove them at night, or
Yes.
kind of what's that process look like?
Yes. So when we turn them on, there's a device. So there's a receiver, or there's a processor, a microphone and a sound processor that's connected to a wire. And then there's a magnet that'll magnetize to a coil on the inside. So you don't see anything on the, outside of the ear when the thing is implanted. But when you kind of engage the external processor to the implant, then it connects to it with a magnet through the skin. So, and there are kinds that they're kind of behind the ear with a little wire that connects to a little disc, or now they have some that are just discs that just kind of pop back there. And certainly certain ones have different battery lives and rechargeability versus batteries and that type of thing. But typically we want kids to wear it as many of the waking hours as possible. And then yes, you take it off for sleep, charge the batteries, or charge the device, whatever the case may be.
Yeah. And is this type of surgery something that is there like a failure rate or anything like that to where you may have to go back in there and do anything in the future? Or is it typically in most cases like a one-time thing, and usually that's all they need for their lifetime?
Thankfully, in most cases, it's a one-time thing. Now, I will say, it's a man-made device, so there's always, just like we were having computer issues earlier today.
Right.
There's always the potential for that to happen, but they're very rigorously tested. I've been to 2 of the 3 manufacturing units for cochlear implants, and it's amazing to see that process. I mean, as far as the exact specifications, the rigorous testing that these implants undergo, and we even of course test it even right when we're implanting it, and that's our last opportunity to say, yep, this thing's in good working order. But yes, there have been, thankfully, very low potential for device failures, either from like electronic component standpoint, or from like trauma. Like I've had some folks who've gotten hit in the head with something, and it moved out of place or damaged or flipped the magnet. But thankfully, that's a very low chance of that happening. There are people who have been walking around for 40 years with the same implant in, and certainly technology is going to continue to get better and better. Thankfully, a lot of the upgrading that we do, I mean, because like if you had your same phone for 40 years, it wouldn't be very good, right? But you can generally upgrade the processor every 5 years, which is pretty good. So the external stuff you can get upgrades on still works with the internal components, and so that's kind of the process there.
Yeah, that's interesting. And honestly, the reason I asked is because I feel like ENTs should get in there with neurosurgeons then, because my daughter has both a VNS and a shunt, and it's like the failure rates on, those. And I know that, it's more like, but it's like you're working for this cochlear implant, like it's not in the brain, but it's like
Right.
close enough, so it's like if the failure rate for that is so low, like shunts are failing like crazy. So I was just curious if there was anything like that with this. So it's good to hear that that's very, very rare, and usually it's a one-time implant, and you're good for decades.
Right.
So that's wonderful. But yeah, that's all the questions I have. I'm glad we did just touch on that, because that's very helpful for parents to hear kind of what the process of the surgery entails, and kind of the road from there. It's been wonderful to have you on. Honestly, I wouldn't be surprised if you have a handful of new Edwards syndrome patients in the next year, because parents are going to come on here and hear this and probably want to travel far to come see you. So, we're very grateful for doctors like you that want to help our kids and other kids with Edwards syndrome. So, thank you so much for doing this with us, and for being so awesome.
Oh, well, thank you. And thank you for this opportunity. And yeah, it's just been a pleasure to work with Crystal and Gunnar, and just be able to kind of get to this point. And so I love every single Edward patient family that have had the opportunity to work with thus far. And it's just, it's exciting to be a part of this. So thank you.